Hi, everybody. Thanks for joining us today. We'll get started momentarily. We're letting folks in from the waiting room. Okay, I think the majority of our group has joined, and so we'll get started. Hi, everyone. My name is Libby Sagara. I've met many of you before as part of our eConsult Coalition and eConsult work group monthly sessions. I'm so glad to see some old faces in addition to some new names on with us today. Today's education session is focused on eConsult best practices for nephrology. If you are a provider, that's wonderful. You are attending a CME eligible session. If you are not a provider, it's an educational session open to all. So as we get started, just want to note that we do have Dr. Delphine Tuot on today, who will be walking us through our educational portion of the session. I'm just going to give a brief introduction, noting that we are so glad that eConsult is growing. We're seeing this grow across the state. We started with an eConsult coalition with a few counties in the Central Valley. And since the past couple of years, we've seen this grow across the state to cover 40 clinics across California. Some of you who are on today may not even be from California. You may represent organizations from across the country. You may have been doing eConsult for 10 years, but we've really seen this grow, perhaps as a result of the pandemic and the exacerbated need for specialty care. But we're really pleased to see that eConsult is being embraced by more and more clinics. We want to note that if you would like to learn more and have more hands-on experience and examples of eConsult in use in clinics, we meet on a monthly basis. Our eConsult coalitions can be found at the link that you see on this slide. And you are always welcome to reach out to us to see how you can get involved in this free resource for providers. Just a little bit more about our eConsult work group. If you are interested in eConsult policy and reimbursement, we have a California Healthcare Foundation supported project, the eConsult work group. It's been around for about 8 years now. Some of you may have been involved in the past. We also meet periodically to really address the biggest challenge, which is provider reimbursement and coverage for all patients. So we'll continue meeting throughout the year. You can see some links to our upcoming calls on this slide here. Just want to note, we work closely with the California Telehealth Policy Coalition to make sure that patients under Medi-Cal are best served through eConsult. And we know that we have continued work throughout this year to make sure that that happens. So you can see links to our upcoming calls in April. We welcome you to join. If you would like to receive materials about our work, please do reach out to Meg Huang. Her email is listed here. And we'll make sure that you have all these links in your email following this call, since I know it's hard to capture all of these on a webinar. Our eConsult Coalition meetings continue to provide the on-the-ground support for providers. So in April, we'll be meeting once again at an eConsult Coalition roundtable to discuss best ways to engage with providers and patients and hear patient and provider perspectives that we've been able to capture from the field. So with that, I'm just going to go through a couple of our required slides that we have to note here that we're really pleased to be able to offer continuing medical education supported by the Weitzman Institute. And this joint accreditation is provided by the AAPA, in case you're wondering. And I just wanted to note that there are no conflicts on today's call with our faculty, Dr. Delphine Tuot. So with that, Delphine, I'm going to hand it off to you to get started. Delphine Tuot has been an advisor to our work for probably about 8 years now, and I know you've been doing eConsult for over a decade, Delphine, so I'll let you introduce yourself and your background, but Dr. Tuot is just such a wonderful resource to have available to us and sharing her deep experience in eConsult. So thanks, Dr. Tuot, I'll hand off to you.
Great, thank you so much. Thank you for the opportunity to present here today. I hope you can all see my slides. I will be talking about ways to leverage eConsult to maximize kidney health. As many of you know, I am the actual e-consultant for nephrology for the San Francisco Health Network. And so I've been doing that for many years now. And so what I thought I might take the opportunity is to actually grab some true e-consults that were sent my way in the last month and talk about how we can leverage eConsult to, in real time, improve kidney disease. And this is very provider sort of centric. And so I do want to make sure that if folks have questions or if I'm going too in the weeds on the details of kidney disease, please do interrupt me and ask me questions. I can talk about the kidneys for many, many hours at a time. So please feel free to interrupt me. So my objectives for today are for you to learn about nephrology topics that can be addressed in an e-consult, understand the importance of chronic kidney disease identification, how to complete a CKD workup and evaluation, and appreciate how effective communication can support nephrology treatment in the primary care home. So first off, let's start about why we should care about kidney disease. So kidney dysfunction and albuminuria are both associated with early all-cause mortality. Here on the left-hand side, you see that on the x-axis is estimated GFR. So that's an estimate of how well the kidneys are filtering and cleaning the blood. Here, normal is 90 to 120. And you can see here that as you go below 60, which is where we consider the cutoff for chronic kidney disease, the lower you go, the higher the age standardized rate of mortality. And this is these data are not new. We've known this for a long time. Equally important is not only the way that kidneys filter their blood or their ability to filter their blood, but also the ability to hold on to protein. And so you can see here on the right-hand side that for every bucket of estimated glomerular filtration rate, so 90 to 120, 60 to 90, or 50 to 60, the more albumin you have in the urine, so the more albuminuria, the leakier essentially the kidneys are, again, the higher adjusted incidence rates of all-cause mortality. And so because of this recognition that those two key concepts of kidney physiology, the filtration and the albumin barrier, both of them really are important in kidney health. And so this heat map came out in 2012 that shows the risk of CKD progression to end-stage kidney disease with both the GFR stages from stage 1 to stage 5 and albuminuria stages, stage 1 to stage 3. And so important to note here is that somebody with a GFR, so a glomerular filtration rate of 30 to 44, so one would say moderate chronic kidney disease, is at the same risk of end-stage kidney disease as someone in this category here that has a mildly decreased GFR of 60 to 89, but has lots of protein in their urine. And this recognition that the proteinuria confers just as much risk of the GFR is something that's more newer, I should say, and is important to understand in kidney disease. And so so that prefaces the rest of the talk. And so I would say, when should you refer to nephrology in general? When the underlying cause of kidney disease is not clear, and we'll get to that in a second, sustained rapid progression of kidney disease, cardiovascular risk or ESKD risk reduction, and then other non-chronic kidney disease issues, which include hypertension that's refractory to treatment, electrolyte and acid-base abnormalities, nephrolithiasis or kidney stones, and medication safety. So I would say whenever you're not comfortable. And because there's not always a nephrologist available to see patients, I think the same list is true for e-consults, and that's what we're going to go through for the next little bit. So let's start with a couple examples. This is an example of preventing contrast nephropathy. So I got this e-consult just last week. So this is a 52-year-old male without any past medical history, status post a recent hospitalization for a GI bleed, had acute kidney injury during that hospitalization with a creatinine of as high as 6.2 milligrams per deciliter. He had some dialysis and then left against medical advice. He's back and his creatinine now in my clinic is 1.1. I need to get a CT scan to assess for abdominal pathology. Is it okay to give contrast to this patient? And should he receive pre or post IV hydration before the CT scan? And so my reply, so thanks for this consult, assuming that his creatinine provides a fair assessment of kidney function, so that he's non-frail, non-cirrhotic, doesn't have an amputation, then it's okay to give IV contrast for the CT scan. And while he had a recent impressive acute kidney injury requiring dialysis, his renal function has improved substantially. And so now he essentially has fairly normal renal function. Again, assuming that creatinine is a good marker of kidney function for this patient. And then with fairly normal creatinine and a lack of diabetes and lack of protein based on the labs that you sent us, I don't think he's at high risk of contrast-induced nephropathy, so I don't think he needs pre-post hydration. So it's a fairly simple question with a fairly simple response that I was able to give in an e-consult to this provider, who now feels comfortable ordering a CT scan without hydration for his patient. Also, my hope is that by giving some of these pearls about what constitutes increased risk of contrast nephropathy, this provider may have a better sense of when to ask this question in the future or when to order pre-post hydration before a CT scan in the future. The other thing that I wanted to give the other pearl that I wanted to start introducing to this clinician as the e-consultant is that creatinine is not always the best measure of kidney function, but that in this case it might be an adequate enough marker. And so this is where I just want to highlight screening for chronic kidney disease. This is a gentleman, I'm just going to go back for a second. This is a gentleman who did not have any past medical history, probably didn't have a lot of creatinine potentially before he was admitted with a GI bleed. And now he has he had an acute kidney injury, but now his creatinine is back down to normal. So just to highlight here that the most recent guidelines, which actually date back now to over a decade ago in 2012 and 2013, suggest that there's actually no benefit for screening asymptomatic adults for chronic kidney disease. Note that that was not because there was evidence to suggest that screening was not important, but that there was no evidence available. This actual guideline is being reviewed currently by the USPSTF, and so we'll see what they come up with their new review of the evidence. But it is important to note that this is that there is no evidence for screening for asymptomatic adults without risk factors. But there are many risk factors for chronic kidney disease, including diabetes, hypertension, cardiovascular disease, family history of kidney failure, and an acute kidney injury history like this gentleman here. So this gentleman had an acute kidney injury requiring dialysis. Now his creatinine is back down to normal, but we should be monitoring his creatinine moving forward because he is now at increased risk of chronic kidney disease. So how does one diagnose chronic kidney disease? So this is where it's important to not only check a serum creatinine so that you can get an estimated glomerular filtration rate, but also check the urine for a urine albumin to creatinine ratio. And the 2020 recommendations from KDIGO, the Kidney Disease International Global Outcomes, is our international professional society, suggests that if somebody has a creatinine-based GFR between 45 and 60, or in individuals in whom creatinine is less accurate, then a serum cystatin C may be a surrogate marker to use and maybe an alternate marker that may be more accurate in identifying their glomerular filtration. And that both creatinine and cystatin C and the urine, so all three of those, are affordable in high income settings. I would say that being said, serum creatinine is still about 10 times the price, or serum cystatin C is still about 10 times the price of serum creatinine. And so I do not use it with as much frequency as potentially others, because I work in a safety net hospital and want to be judicious, use our resources judiciously. But it is important to note that I do use it when I don't think that the eGFR creatinine is accurate. And when are those situations? I don't see kids, but in children, the eGFR creatinine may not be accurate. Individuals who have odd nutritional habits, or individuals who have tea and toast diets, individuals at the extremes of muscle mass. So amputees or people with cirrhosis have very little muscle mass, right? If you have an amputation and you're missing a leg, that is a lot of muscle mass that you're missing. And therefore your creatinine should be lower than if you had the pre-amputation. On the other end of the spectrum, bodybuilders have very large muscle mass. And so a creatinine for them of 1.3 or 1.4 may actually be normal. And that's not going to be reflected in your estimated GFR. There's also some medications that interfere with creatinine secretion in the kidney, and therefore their estimated GFR based on creatinine may not be accurate. So what do? When in doubt, so in these situations, I will measure the cystatin C and measure a kidney function creatinine at the same time, compare the two, and use that moving forward, so that I'm not checking consistently a cystatin C because it's much more expensive. So that was about preventing ongoing kidney injury in somebody and introducing the concept of cystatin C potentially and to estimate GFR. Let's talk about another e-consult I got recently for diagnosis of chronic kidney disease. So this is a 34-year-old male, Spanish speaker, recent tibia and fibula fracture. He said he was diagnosed with type 2 diabetes 1 year ago in Mexico. He's on metformin, which is an appropriate medication for his diabetes. He's normotensive, does not have any antihypertensive medications. CBC is normal, eGFR is normal, creatinine is normal. His A1C is extremely well controlled at 5.1%, and he has a urine albumin to creatinine ratio of about 430 milligrams per gram, no diabetic retinopathy. So the question to me was, does this patient need a renal biopsy or further workup? And namely, this provider said, I know his GFR is normal, but his urine albumin to creatinine ratio, so on that x-axis of, eGFR and albumin, that albumin was really high. And I know that portends increased risk. What do I do about this? Does he need a biopsy or further workup? And so I answered and I said, this degree of albuminuria is actually consistent with diabetes exacerbated by obesity. So while the e-consult did not include weight in it, I was able to see the primary care notes that were attached to the e-consult, and I noted that his recent weight was 115 kilograms. However, lack of diabetic retinopathy and a recent diagnosis of diabetes does raise the possibility of other etiologies of proteinuria. So I said, we will schedule to see him in clinic. But in the meanwhile, I would recommend obtaining the following. And so I asked for a urinalysis with microscopy because the presence of hematuria broadens my differential diagnosis. It's not just diabetes, but many other things. I asked for viral hepatitis serologies and HIV tests and a history of over-the-counter medication use. Now, this is an example of an e-consult that, yes, I actually think we need to schedule this person in. Somebody in a nephrologist should see this person because his diagnosis of diabetes was relatively recent and he has no retinopathy. Diabetes affects the eyes and the kidneys, the capillaries, the glomeruli at roughly the same rate because they are roughly the same size, the retinal capillaries and the glomerular capillaries. And so in general, those two work in tandem. So when they are disparate from each other, someone does not have retinopathy but may have diabetic kidney disease, you want to be sure that that's the case. But the reason why this e-consult is really helpful is, one, to confirm that suspicion from the primary care provider. So yes, we should see this person in kidney clinic. And two, when he comes to kidney clinic, now he will be much better worked up. He will have all these other blood tests that are important for me as a nephrologist to evaluate this person in clinic. And so this is my cue to give you a little bit of background on diabetic nephropathy. So diabetic kidney disease is the leading cause of kidney failure in the United States. And usually it uniformly has proteinuria, but that proteinuria or albuminuria occurs before the loss of GFR. So just like in this patient here, he has proteinuria, and his GFR, his kidney filtration or function is actually perfect, but he's leaking protein into the urine. That microalbuminuria often develops at about 5 to 10 years after the diabetes diagnosis, which is why this person did not fit that general epidemiology or natural history. As I mentioned, patients often have retinopathy and diabetic kidney disease at the same time, though approximately 30% of type 2 diabetics do not. So when you see that discrepancy, I think that is a reason to send an e-consult to nephrology or send a referral to nephrology. We will say about a third of the time, we may end up biopsying that person, doing a kidney biopsy and show that they do have diabetes in their kidney. Very advanced diabetes may be associated with hematuria, but it's not that common in earlier stages of disease. And that's why I asked for a urinalysis with microscopy to assess for hematuria before this person comes to see me in clinic. Untreated disease can unfortunately progress really quite rapidly, and then aggressively treated disease, you have a GFR loss of 2 to 4 mils per minute per year, so a much more gradual progression of chronic kidney disease. Let's talk about another e-consult for a CKD etiology. This is a different individual. This is a 69-year-old woman with pre-diabetes, so doesn't actually have diabetes. Her A1C, I think, was 6%, if I'm remembering correctly, but I got this e-consult maybe 2 weeks ago. She has hypertension, hyperlipidemia, microscopic hematuria, and proteinuria. She had a cystoscopy done in 10 of 2022, and the biopsy just showed cystitis. She's followed by urology. I'm given some albumin to creatinine, urine albumin and urine creatinine measures so that the ratio is 1650 milligrams per gram. Basic metabolic panel, so renal function or creatinine was normal. Does this person require further tests? So again, this is a person with hypertension, with hematuria, but who's had a fairly negative workup in urology. So because they have hematuria and proteinuria, should this person get further workup in nephrology? So I say, great, thanks for the consult. So I suspect her albuminuria is from hypertension, but with the hematuria, so that blood in the urine, in the setting of an unimpressive urology workup, we should engage in further testing. I provide some recommendations, in particular, sort of a urine protein to creatinine ratio, which differs from a protein albumin to creatinine ratio. Her albumin to creatinine ratio was 1600 or so, just to see whether, again, there's a discrepancy there. A C3 and C4, so complements are often low when you have a glomerular nephritis, which is a concern in somebody who has hematuria. INR, in case we want to biopsy this person, and just a repeat kidney function test. And then in addition to these labs, in terms of management, what do I recommend? I recommend discontinuing the amlodipine for this person, which while the provider did not give me the list of medications, it was in the provider note that was attached to the e-consult. And so I said, look, I would recommend discontinuing the amlodipine and starting at an ACE and an ARB, not only for blood pressure control, but for proteinuria minimization, because they have an albumin to creatinine ratio of 1650. I said I would start low. I provided some recommendations and then some anticipatory guidance. Please check a renal panel 2 weeks later to assure stability of the potassium and serum creatinine. And if your blood pressure remains elevated, but the serum studies are stable, you can titrate up your ACE and your ARB. So important here is that I'm recognizing that this patient does not fit the norm. So confirming that to the primary care provider that yes, this person requires some additional workup. I provide what that workup needs to be, and then I give them some recommendations that they can start in primary care. And that way, if they do need to see me in nephrology, somebody else, a nephrologist, they're going to be better worked up so that we can make a diagnosis or decide to discuss that kidney biopsy with the patient in that first meeting with them, or we can treat, if all the workup is negative, then we feel comfortable they can probably stay in primary care and we can just help them titrate their medications to minimize their albuminuria. So I actually got a reply back just this week actually and said, please see attached for updated results. So this primary care provider followed through with the recommendations that I provided. And importantly, the complement levels were both low. So C3 and C4 were both low. Clinic BP was high. She said due to white coat hypertension, the home BP is always less than 130 over 80. So at this point, because the complements are low, I actually do feel like we need to see this person in a nephrology clinic. And so I recommended that this person be sent into clinic. Had the complements been completely normal and the rest of the workup been normal, then I'm not sure that we would have needed to see this person in nephrology clinic immediately. So again, the point of this e-consult is to confirm suspicion, to provide initial workup, and in this case, identify somebody who actually should be seen in nephrology clinic for next steps. And so I think this person is actually scheduled to see a colleague of mine next week in clinic. So what to include in an e-consult about a CKD diagnosis? The two last cases here was about diagnosing the cause or the etiology of kidney disease. So a great e-consult includes the one-liner and the question at hand. Does this person need a kidney biopsy? Do I need to do additional workup? Do I need to get an imaging study for this patient? Any pertinent changes in physical exam is helpful. Edema in particular, weight gain or weight loss, this is part of your general question for the e-consultant. And then what lab should you order before submitting an e-consult? always, always, always get a urinalysis. You'll note that in both of in the first case that they didn't have a urinalysis, I suggested, please get a UA and then get back to me. The second one, that case already had a urinalysis, and that showed some blood in the urine, which is what raised my suspicion that this person needed additional workup. So in general, always recommend a urinalysis before you send an e-consult. Urine gives us a ton of information. And as a nephrologist, I'm particularly in tune to that. A spot urine protein or albumin to creatinine ratio. Again, this shows the health of the kidney, the health of the glomerular basement membrane, and if they are leaking protein into the urine. This is extremely helpful for the nephrologist to help triage and identify, does this person need to be seen in a kidney clinic, in a nephrology specialty clinic, or not. And then lastly, a renal panel, so how the patient's kidneys are filtering. If the urinalysis has protein, then I have some other recommendations here. If the urinalysis has blood, then I have some additional recommendations. And these recommendations are actually in our page, like our e-consult policy page. When somebody comes onto the e-consult for nephrology and is going to submit an e-consult to me, these are the recommendations. You'll see that they're not always followed, but if they are not, then I often reply and say, hey, can you get these for me? Because these are really important for me to determine next steps. So I have one more here about CKD diagnosis. So this is a 50-year-old woman with hypertension, well controlled on chlorthalidone, which is one of my favorite blood pressure medicines, actually. Her older brother just started dialysis unexpectedly. Her serum creatinine is 0.7, estimated GFR of 75, and a UACR of 450 milligrams per gram. My questions: can I attribute her proteinuria to hypertension? And what should I do for the proteinuria? So this is a perfect e-consult. It gives me a one-liner. It gives me the important physical exam. So in this case, the vital sign, and some important laboratory tests, and actually delineates 2 specific questions that they want me to answer as their e-consultant. So I reply and I say, yes, thank you for this consult. This degree of albuminuria is consistent with hypertension as the diagnosis of, or the cause of the kidney disease. But to be thorough, please attain a UA because the presence of hematuria would broaden the differential diagnosis. And then I say, did her older brother, who just started dialysis, have a kidney biopsy, or does she know what caused his kidney disease? Again, starting to think about, okay, is there a genetic component of this kidney disease in this woman? And then with respect to management, congrats to you on her on achieving a target blood pressure control at this point, and then I provide some recommendations for the proteinuria. So I'm answering sort of this second question. So start an ACE or an ARB, check a renal panel, providing anticipatory guidance, which is a really important aspect of being the e-consultant. So we generally tolerate a rise of serum creatinine of less than 30% and a K as high as 5.3 milliequivalents per deciliter. So continue to titrate up your ACE and your ARB medication until your blood pressure remains at goal and the UACR is less than 300 milligrams per gram on this new medication. Feel free to write back if you have more information or if the titration process is challenging. This I got actually about a month ago, and I haven't heard anything back yet. So hopefully that patient and primary care provider are slowly titrating up their ACE and their ARB without too much challenge, and we'll see what her repeat UACR is. And I suspect if it's not below 300 milligrams per gram, that I will get a response to this telling me, okay, I've done everything you said, now what? And so we'll be able to see what the next steps are. And if that were the case, I would probably end up seeing this person in renal clinic, but I will see her, one, in a more worked up fashion, and 2, on the initial medications that I would have wanted to start anyway. So it saves at least 1 visit with me, if not 2, because at the point that this patient may end up seeing somebody, me, a colleague in nephrology clinic, their blood pressure is going to be under control. They're going to be on the ACE and their ARB with the minimal amount of proteinuria with those medications. And they may need extra interventions to decrease that proteinuria, but that's really within the scope of nephrology and less so within primary care. So that's us working as a team to the top of their license. One quick slide on hypertensive nephrosclerosis. So hypertension is both a cause and a consequence of kidney disease, as we assume or suspect that this was the cause of her kidney disease, this 50-year-old woman with some albuminuria. It's classically a vascular disease, so less proteinuric than diabetes, but some protein in the urine is expected, actually. Typical age of onset is 30 to 50 years, and so she was at that end of that age range, so quite typical. And a mean rate of loss of eGFR is about 2 mils per minute per year if your blood pressure is well controlled. Her blood pressure is well controlled, so that's what I assume will happen moving forward. And I like this slide because this is a slide that I really share often with primary care colleagues when I'm giving lectures or talks. And the quantification of proteinuria is not only important because it identifies who's at higher risk of cardiovascular disease and all-cause mortality, which I mentioned at the very beginning of our discussion here, but also it helps to identify what part of the kidney is injured, right? In somebody with just hypertension, that's usually just vascular, you have minimal to small amount of proteinuria. If you have somebody with diabetes and a glomerular injury, you can get a lot more proteinuria up into the nephrotic range. And we have many individuals who have both comorbid hypertension and diabetes. And so the amount of proteinuria is actually helpful because if someone has 2 grams of proteinuria per day, it is not likely to be the hypertension that's causing the kidney disease. It's more likely to be the diabetes. And while this doesn't necessarily impact your initial management, it is helpful to think about what part of the kidney is being injured. So this is an example of an e-consult that I got because we have a combined e-consult and e-referral system. But I put this in here because this is a consult that should not have actually been an e-consult. This is something that if somebody had a separate e-consult portal and a referral process, this is somebody who I think should have been referred from the get-go. And this is why. So I just want to throw that in here as an alternative, essentially. So this is a 61-year-old man with diabetes and new palpable purpura with concern for leukocytoclastic vasculitis, LCV. Labs show an elevated creatinine, and the direct immunofluorescence on the skin biopsy is pending for IgA. Please evaluate for renal involvement. I'm getting a urinalysis. So this provider knew to get a UA, hadn't gotten it yet, and sent this to me. And so because we have a unified e-consult and e-referral system, I can look at this and triage and say, okay, this person needs an urgent nephrology appointment in the next 10 days, any provider. So this was my note to the scheduling team, not back to the primary care provider. But if there had been 2 separate portals, this is something that a primary care provider should have sent directly as a referral, not as an e-consult. Because this is somebody with new skin findings and elevated creatinine, and this person is clearly concerned for a new underlying glomerular nephritis that is rapidly progressing. So just to give that context that this can be helpful, and I can reply and say, hey, thanks for the urgent consult. We will schedule him immediately, which is what I did. But this is just an example of somebody who should be referred as quickly as possible. And the primary care provider kind of knew that, right? You can tell based on the urgency of this consult. So now let's move on to management of kidney disease. We just saw a bunch of recommendations, or we just saw a bunch of examples of e-consults for diagnosis of CKD and etiology of CKD. How about just management? So this is an example I just got recently, a 73-year-old with diabetes, recent hospitalizations for diarrhea and hypovolemic shock. ACE-ARB was discontinued. See attached for MedList. There was a recommendation to permanently discontinue the ACE-ARB since she is prone to hypovolemia. Her UACR is over 2,000 milligrams per gram. Is giardins the best option now? So again, this question is, okay, what should I do now? I was recommended to stop ACEs and ARBs. ACEs and ARBs are the first line treatment for albuminuria. Is giardins my next step? And giardins is an example of an SGLT2 inhibitor that is now one of our new kids on the block to treat albuminuria among individuals with and without diabetes. And we'll get into that in just a second. So my reply, so thanks for the consult. That's a marked change in her UACR compared to 6 months ago. So again, here, her UACR is 2,000 milligrams per gram. She didn't tell this primary care provider, did not tell me what her previous UACR was in the e-consult, but with the attached primary care provider note, the attached med list, and the attached laboratory test, I see that 6 months ago, it was not nearly as high. But I suspect that this high UACR is related to hypertensive urgency, because on the day of your clinic visit, in what you attached, her systolic blood pressure was through the roof. It was 200 milligrams per, or 200 millimeters per of mercury per systolic blood pressure. So I say, let's repeat the UACR once her BP is better controlled, and then we can decide upon next steps. And then I provide, while this was not specifically requested in the e-consult, I do provide some recommendations for blood pressure management because her systolic blood pressure was over 200 in that clinic visit. So I say I would increase the labetalol dose. I wonder about spironolactone as a second agent. If achieving blood pressure control is challenging, let me know so I can co-manage from afar or schedule to see her in clinic. And again, this is because this provider has said, look, I was told to discontinue the ACE and the ARB, which is a good blood pressure medicine. What am I supposed to do next? And so I reply, increase the labetalol dose and try potentially this other medication. If that doesn't work, let me know, and this person will be seen in clinic. This is, again, helping primary care provider work to the top of their license before a patient then officially has resistant hypertension. So they're on several medications and then needs to be seen in nephrology clinic. In response to her second question, is Giardiance, or really her main question, is Giardiance the best option for her albuminuria? So I reply and I say, hey, actually, I worry about an SGLT2 inhibitor in this particular patient because it predisposes to volume depletion, even more so than an ACE and an ARB, because they cause, SGLT2 inhibitors can cause an osmotic diuresis. So I would try to achieve blood pressure control first, then optimize volume, and then we can decide on the SGLT2 inhibitor. So this is a great e-consult because I am now, this primary care provider would have probably started Giardiance, which in general is a great medication, but in someone who's prone to hypovolemia may actually cause more harm than benefit initially. And so I'm glad that I was able to counsel this primary to not do that right away. Let's achieve blood pressure control and volume status first. And so talking about general CKD management strategies, right? We've talked a little bit about proteinuria minimization. We've talked, and I'm going to talk a little bit about blood pressure control, what I was just saying for this patient here. If we control blood pressure, their albuminuria should actually improve. And there's also some cardiovascular risk reduction, which is important for general CKD management. And that really includes these days SGLT2 inhibitors, statins, for cardiovascular risk reduction, and then GLP-1 receptor agonist in individuals with diabetes or obesity. So let's talk a little bit about blood pressure, because I started to provide some anticipatory guidance and some recommendations for the blood pressure for this patient who presented with hypertensive urgency. So what is target blood pressure in chronic kidney disease? This I find is changing every couple of years because of the relatively recent SPRINT trial, which randomized about 9,000 patients to a systolic blood pressure target of 120 versus a target of 140. About a third of those patients had chronic kidney disease. So this was actually huge for individuals with CKD and was really important for the nephrology community. The trial was actually stopped early because there was a mortality benefit in the strict blood pressure control arm. This was also true among individuals with chronic kidney disease, so in that subgroup of 3,000 patients, and in the subgroup of older individuals of 75 years and older. This you see here is the Kaplan-Meier curve for the subgroup of patients with chronic kidney disease, so that 2,600 patients or so. And you can see here that the strict blood pressure arm had less cumulative hazard of all-cause mortality than the liberal blood pressure arm. And so because of this, my target now for patients with CKD is largely as close to 120 to 80 as I can get. Now, note that in the SPRINT trial, that strict blood pressure arm was a target of 120 over 80. The actual blood pressure that they achieved in that arm was actually 123 or 124 systolic. So it didn't quite make the 120. So that's fine. I target 120 knowing that I'm not always going to make it there with our patients. And then my target for patients who are older and frail is higher than this, not coming from the SPRINT trial, but coming from earlier data. So in SPRINT, the people that were actually older and able to participate in the trial they had a mortality benefit with a strict blood pressure control arm too, largely because of the decreased stroke risk. So I tend to think in looking at a patient in front of me, would they have been able to participate in a trial? Would have they been able to go to a visit every month with a doctor? If so, then I probably try to be more strict. If they are individuals who are frail and would have never been able to participate in the SPRINT trial or another trial, then I tend to be more liberal because I worry about orthostasis and them falling down. Preferred agents in chronic kidney disease for blood pressure are ACEs and ARBs, particularly in the presence of proteinuria, as we have mentioned before. Diuretic is often my second line agent. I love chlorthalidone because it is potent and long acting. The other reason to include a diuretic with an ACE and an ARB together is because the diuretic helps control the serum potassium and increases caluresis. Second line or third line agents, I should say, kind of depend on the side effect profile that you're looking for. So calcium channel blocker or a beta blockers, particularly if someone has known congestive heart failure with reduced ejection fraction. And then lastly, you'll remember maybe in the last case that I actually recommended spironolactone as an excellent blood pressure medication, but you do need to be careful with hyperkalemia. So in the patient that was in the e-consult example that I provided, it was a patient who could not be on an ACE or an ARB because of their fluctuating creatinine, and not on a diuretic because they were or a loop or a thiazide diuretic because they were prone to hypovolemia. And so they were already on a beta blocker, the labetalol, that I recommended to titrate up, and then I provided spironolactone as another option. Talking a little bit about cardiovascular risk reduction and the giardians, the SGLT2 inhibitors that this particular e-consult asked about. So I don't know if many of you have seen or heard or have used SGLT2 inhibitors, but they are essentially, they block this SGLT2 co-transporter in the proximal tubule of the kidney. And so this is a sodium and glucose co-transporter. So by blocking this, you're going to get more sodium and more glucose in the nephron. And that's going to be here. You're going to have a higher concentration of both of those at the macula densa. This then gives this wonderful process called tubuloglomerular feedback. It's essentially a feedback loop, then essentially tells the kidney, oh, you should constrict your afferent arteriole because you have so much sodium and so much glucose here. So the sodium and glucose comes down, so you get a natriuresis effect and an osmotic diuresis effect from the glucose. So that helps decrease your hemoglobin A1C and improve diabetes control because you're essentially urinating out glucose. It also helps you decrease weight and decrease blood pressure because you have this natriuresis. You're losing sodium in the urine as well. But even more importantly than those two things, through this tubuloglomerular feedback, you get decreased intraglomerular hypertension because that afferent arteriole gets a little bit smaller. And so your blood pressure essentially within the capillaries goes down. And so you get less proteinuria. And this, we think, while there's still studies underway, we think this is the primary physiologic reason why SGLT2 inhibitors leads to decreased cardiovascular risk and decreased risk of end-stage kidney disease. And so there have been now enough studies, randomized controlled studies, that there's some meta-analyses that have come out in the last couple of years, and SGLT2 inhibitors reduce cardiovascular risk across a large range of GFRs. Here you see a GFR from 30 to 90. So you see the greater than 90 subgroup, the 60 to 90, 45 to 60, and an eGFR of between 30 and 45. And you can see here that largely they all favor the SGLT2 inhibitor in this forest plot. It also reduces risk across a large range of UACR categories. So we usually think about it as having the most effect in individuals with high UACR. So in that last e-consult example, that woman had a UACR of over 2,000 milligrams per gram. And yes, it is quite favorable in those patients, but SGLT2 inhibitors can also be favorable in individuals with lesser amounts of proteinuria. But most and all of the trials have done an SGLT2 inhibitor within the context of already being on RAS blockade. So as much RAS, as much ACE inhibitor or ARB that a patient can tolerate. There were individuals that cannot tolerate an ACE and an ARB, and you can still give those individuals an SGLT2 inhibitor, and it is very likely to be beneficial. But you can see here that among individuals with a RAS blockade in these meta-analyses, there was a clear benefit to the SGLT2 inhibitor. In individuals that could not tolerate RAS blockade, so couldn't tolerate an ACE or an ARB, and so were randomized to the SGLT2 inhibitor versus not, it still favors the SGLT2 inhibitor, but it does officially cross one. So I just want to point that out, that we are less confident in the independent benefit in an SGLT2 inhibitor if you cannot be on a RAS already, essentially. So this is why I always try to start RAS blockade, titrate it up as much as possible, and then add the SGLT2 inhibitor. And this is just to remind me to mention that SGLT2 inhibitors reduce the cardiovascular risk both in individuals with and without diabetes. It was found out and investigated and came about as a diabetes medicine because it helps with glucose control. But honestly, it works just as well for cardiovascular risk in non-diabetics because of that tubular glomerular feedback. And these are the composite outcomes of the DAPA-CKD trial, which looked at one of the SGLT2 inhibitors versus placebo. And you can see here, I'm just going to take this, for example, death from any cause. The dapagliflozin had less death compared to placebo. And in this trial, they had equal individuals with and without diabetes. Just want to offer some practical considerations for people who you're prescribing an SGLT2 inhibitor for, because this came up in that e-consult that I was recommending. So it's individuals who have high UACR, who have an eGFR of over now 20, but when the slide was made over 30, you're going to give them an SGLT2 inhibitor. I do provide sick day recommendations. So if somebody does not feel well, if somebody is not hydrating well, I worry about the impact about causing hypoglycemia or hypovolemia in these individuals. And so I try to educate people. If they're at a high risk of volume depletion, consider either decreasing your diuretic dose before you start the SGLT2 inhibitor, or say maybe this person is not the right person to get an SGLT2 inhibitor. And I tell patients, if you're feeling crummy on a given day, maybe this is not the medicine you should take on that particular day. But you shouldn't stop it for most of the time, right? You should only stop it when you're feeling crummy on any given day. I also usually remind providers that while SGLT2 inhibitors do not induce hypoglycemia, they're wonderful in that way. If someone is already on insulin or sulfonylurea to treat their diabetes, and you give them an SGLT2 inhibitor, you should be careful about those other medicines, the insulin and the sulfonylurea, which can cause hypoglycemia. And so it's important to potentially dose reduce those medications. Okay, I am actually going to skip this slide because I recognize that we're getting close to time. I do want to mention the other kind of newish kid on the block for diabetes control and cardiovascular risk reduction are GLP-1 receptor agonists. You can see here that these are the 2020 KDIGO guidelines that recommend for diabetes for management, often start with lifestyle intervention. The first line medication therapy is still metformin. Please remember that metformin is still your first line agent for diabetes among individuals with a GFR of over 30. If you're less than 30, you need to stop the metformin. SGLT2 inhibitor together with metformin or as a second line agent is your sort of next line of therapy, I would say. And then once you're on both of these and you still need extra diabetes control, then a GLP-1 receptor agonist is probably your next way to go because it has benefits on decreasing proteinuria, improving kidney function, and decreased all-cause mortality and cardiovascular mortality. So you can see here, I'm just going to talk about this graph on the left-hand side, that this is your eGFR creatinine in the Award 7 randomized controlled trial that was a randomized controlled trial of dulaglutide, I can never say these, which is one of the GLP-1 receptor agonists at 2 different doses versus insulin. And you can see here that the insulin group had a larger decline in estimated glomerular filtration than the two dulaglutide medications. And so again, SGLT2 inhibitors or GLP-1 receptor agonists, similar to SGLT2 inhibitors, are helpful for cardiovascular risk reduction and, importantly, as this slide shows, slowing the progression of CKD. So I also want to take just 1 minute or two to talk about electrolyte abnormalities. So these are other reasons why you might want to send an e-consult to a nephrologist. This is something that often can be taken care of in the primary care setting, and you can avoid then a specialist visit for this patient. So this is a gentleman with history of hypertension, SVT, alcohol abuse in the past, now in sustained remission, who has a serum potassium in the low 5.2 to 5.3 range. So not super high, but definitely on the higher end of normal. And this primary care provider is not feeling comfortable with that. This primary care provider discontinued the ARB therapy, and still the potassium was elevated. He has no official history of CKD, and this new hyperkalemia is a new problem. And so this was an older excuse me, this is an older e-consult actually. So labs from early 2020 show this level of potassium. You can see here that they're persistently in the low fives. So this primary care provider added hydrochlorothiazide, so a thiazide, to not only help with the blood pressure, but also help reduce serum potassium, and increased that value, but still the potassium level remains elevated. So what are your recommendations for further workup and management? So I say, thank you for the consult. It's interesting that he's never had this issue in the past, right? So confirming, yes, I recognize this is a new issue. My guess is that this may have been from poor nutrition in the past in the setting of alcohol abuse. Now he's in remission, he's eating much better, and now his issue arises, essentially emerges. So as a first step, I would ensure that he's not taking NSAIDs. So those are chronic non-steroidal anti-inflammatory medications that can cause hyperkalemia. And so that's a clinical pearl that I'm giving the primary care provider. And then I would obtain some urine studies to evaluate whether this is a problem with the renal handling or not. And so I make some recommendations about what to check for this person. And then I say, if there's evidence of poor renal excretion, so if these studies suggest that your TTKG, which is the transtubular potassium gradient, or the amount of the potassium to creatinine ratio in the urine, so the amount of potassium being in the urine is not what you would expect for this degree of serum potassium, then best that he sees a nephrologist to initiate management. So feel free to respond to me when these labs are back so I can help guide next steps. Again, this is an example of a patient who eventually saw one of my colleagues in kidney clinic for evaluation of hyperkalemia, but this was a person who came and already had all of the appropriate workup, so that in that first visit with the nephrologist, we could say, okay, this is a kidney handling issue. This is what we're going to do. So it saved actually at least one visit with a nephrologist. And this provides additional education to the primary care provider. My hope is that this individual can then know how to work up hyperkalemia in the future, so that when they next want to refer a patient to nephrology, they will be further worked up. My last one I wanted to highlight was example of a renal mass. So this is a consult I just got on Monday of this week. So 52-year-old with an incidental finding of 2 kidney angiomyolipomas. Patient is asymptomatic, no hematuria. What do you recommend for follow-up? I'm already ordering a CT with contrast, and we'll recheck the kidney function. How often should we be monitoring this? And so I say, look, make sure that these are sporadic and not associated with tuberous sclerosis. So given her age and the fact that these 2 angiomyolipomas are small, they're most likely sporadic. But I would discuss family history with her and perform a good skin exam. Assuming no family history of tuberous sclerosis, no hypomelanotic skin lesions, then no need for genetic testing. These are sporadic. And so then in the terms of management, I say, okay, I agree with the CT for further characterization, and then rechecking her renal function. No need for cystatin C, which is now a question I get commonly, although this person did not ask for it specifically. And then I say, if the CT characterizes the lesions as small, without any suspicious features, which I assume will be the case, then I would repeat yearly for 2 years, and then you can stop. So giving, again, anticipatory guidance. So this is a patient who otherwise would have been seen in kidney clinic to be reassured that these two tiny renal lesions are benign and that they just need annual CT scans for 2 years. And if they stay stable, then no need for further CT scans. So in summary, chronic kidney disease is common. It affects about 13% of the adult patient population, which is about the same as diabetes, but it doesn't get the same attention as diabetes does. CKD confers the high risk for early mortality and cardiovascular disease. Always quantify proteinuria as an initial part of your evaluation. Treat to goal, so blood pressure, albuminuria minimization, and cardiovascular risk reduction using our two new kind of kids on the block medications of SGLT2 inhibitors and GLP-1 receptor agonists. I would send an e-consult when you're uncomfortable with the etiology of CKD. Your e-consultant can help confirm, yes, we think this CKD is from diabetes, from hypertension. You should feel comfortable moving forward. No additional workup is needed. Or actually, this person has diabetes, but because of what you're telling me, we should do a further workup and not attribute the CKD to diabetes. So when patients don't fit the norm, send an e-consult. We can be really helpful to guide further workup. And then, of course, general management questions, electrolyte abnormalities, blood pressure questions, nephrolithiasis, and medication concerns. And I will stop there. Thank you so much for the opportunity.
Thanks so much, Dr. Tuo. And in our last 2 minutes, I want to open up to see if there are any questions. If you would like to unmute yourself, you may do that. I just have a quick, pretty general question for you, Dr. Tuo. With the great help and really specific instructions you offered for primary care providers, it seems like many of these cases could be managed in primary care, or at least over the course of you seeing a patient, that perhaps some of these issues could be dealt with, maybe not all. Do you feel like a good number of your patients end up avoiding a face-to-face visit by having done any consult or having their primary care provider do any consult with you or a nephrologist?
Yeah, so I think in many of these cases, they have avoided at least one unnecessary visit with me, right? Because they are now coming to visit coming to nephrology better worked up. And I will say in some cases, they can avoid a visit altogether. So for example, some of the hyperkalemia cases, some of the hyponatremia cases, so low sodium in the blood, I can give guidance to them from afar, and patients can stay in their primary care home, which they feel so much more comfortable with, right? They're more comfortable with the staff in primary care, more comfortable with their primary care provider than they are trudging over to the hospital to see me. I will also say some of these e-consults, for example, the one about Giardians asking about an SGLT2 inhibitor, is this now what I should do for this patient? That is a primary care provider in whom I had recommended an SGLT2 inhibitor for many of her other patients in the past. And she's like, okay, I'm recognizing that, Pearl. I'm now going to do it, but this person is a little different. Is this the right approach? Right. So you can see that our providers are learning as they go, which is a wonderful tool for them. It's case-based, and I learn from the e-consults that I send other individuals as well.
That's so helpful. And since we are at the end of our hour, I'm going to offer up the opportunity. If there are additional questions for Dr. Tuo, you're welcome to send them to me and I can share them with her. The link, if you wish to receive CME credit for today's session, is in your chat. But if you can't grab that link, don't worry, we have your emails and we will send this to you so you can capture your CME credit if you wish to do so. Our next event is on April 19th. You can see on your screen. And just want to really thank Dr. Tuo for her time today, and thank you all for attending. Thanks so much.